go ahead. Io direi di andare avanti a questo punto. I'm very glad to introduce Camilo Gutierrez from Washington, D.C. Camilo is the Director of Global Health Programs, Division of Emergency Medicine Trauma Center in Children's National Hospital, and the Secretary of American College of Emergency Physicians International Section, ACEP. Camilo, okay. Thanks.
Okay, thank you. Thank you, Ricardo. So I'll tell you when to go next. So this is my hospital. We're in Washington, D.C. And I'm going to answer the first couple of questions at the same time, which are how is the emergency department organized? How do we manage a patient in the emergency department? And then we'll talk about the other questions. So I don't have a mouse here to show you. Do you see? You don't see my mouse. But if you look in the upper part is the waiting room. We have a fast track and a few beds there. And that's one of the places that we have patient entrance. We can see slides. We had the slides before.
These?
Yeah, but now we're not seeing them. Do you see the slides? I just see myself.
Questa? This slide?
Okay, you're seeing slides? Okay.
We cannot see the slides, Riccardo.
We don't see the slides. We see them before.
We saw them before, but not now.
Non capisco perché non si vede. Pure qui me le dà come... Aspetta. Mi dice che le sta distribuendo.
Schiacciare sull'icona Riccardo.
Dice che le sta dividendo. They said it is on sharing. You see?
There it is. Yeah.
Well, we can leave it there then. So, this is the general department, right? What you see, the red boxes that say negative pressure room on the top of the screen, and then you see all the other purple boxes that say isolation. So the negative pressure rooms are the true negative pressure rooms where we put the patients that we know they're positive or they're highly suspicious, or are those patients that we are doing either aerosolizing procedures, like, if they need BiPAP or high flow. And the other beds that said isolation are those beds in which they're not negative pressure, but they're individual rooms with windows as doors. So the other blue smaller beds that you see also on the right side and on the bottom, those are beds that are divided by curtains. So we're putting there patients.
Non li vediamo però, non li vediamo.
Aspetta un attimo, adesso riprovo, non so come fare, non me lo prende, non so perché, dice che sta dividendo, ma condividendo lo schermo, ma non... Vediamo se riesco a fare questo.
We were seeing the slides before. If you can put them, I can go over it.
Si vede, Raffaele?
No.
Non capisco che succede. C'è qualcosa per cui non lo prendo.
Vediamo la tua, la tua...
Adesso si vede.
Si vedono le diapositive?
Sì.
Io no. Voi li vedete? Chi li vede?
Riccardo, sì.
Devi schiacciare sull'ubrano.
Can you hear me?
Yes, Camillo, yes, I can hear you.
We see you, but
the next slide.
Presentation.
Go up one slide, the bit before.
This slide.
Io non le vedo.
There you go. So, the other entrance part is...
No, non si vede. Io non li vedo.
On the far right side, the trauma.
puoi mettere una connessione normale? Puoi mettere la tua connessione, secondo me è il wifi della...
Camilo?
Perfectly.
Sì, Rafael.
Can you speak, please?
Yeah, okay.
Go ahead, Camillo.
Okay, perfect. Okay, yeah. So I was saying, so the other place that we see patients is the trauma base. All right. So what we're trying to do is when we have elective intubations, meaning the patient that is that's failing BiPAP or high flow and needs intubation, we're trying to electively intubate them in the negative pressure rooms. So we don't contaminate. And if they are in need of resuscitation, then we move them to the trauma base. And we also made a change in our policy. And now anesthesia is going to intubate all our COVID patients to minimize the number of attempts and the risk. Normally, we intubate all our patients, but now we have a team to minimize the number of people in the room and try to maximize efficiency. So we have anesthesia try to do all of intubations. Finally, we have a disaster tent that you see in the left corner, and it's behind me. You don't see it right now, but we're still trying to figure out how to work. We're expecting the peak of patients here within a week to 2 or 3 weeks. So we are already seeing patients there, but as we go, we're trying to figure out how to use this tent better. If we're going to use it for triage, for treatment, we're still in the process of doing that. We're already seeing some patients there and doing that. With regards to protection, all of us are having an N95 mask, a surgical mask, and goggles and a head cover. But if we know they're a positive COVID, or we add a gown, shoe covers, a face shield, of course, and we also have PAPRs if we're going to do something more invasive like intubation or something aerosolizing like an albuterol nebulization, for example. We're trying to use only inhalers if we can, but if they're sick enough that need continuous albuterol, then we're trying to send only one person, the therapist, with a PAPR for that. So also to answer one of the other questions, we are not dividing the emergency department into clean and dirty. Everybody we consider positive. So we have precautions for everyone, and especially in those negative rooms or isolation rooms, we wear more equipment for the other rooms. Also, and actually, you want to go to the next slide, Ricardo.
You lose the connection.
With Ricardo.
Riccardo, la prossima.
La prossima.
Non sentivo più.
Ok.
Grazie. So that's the case definition that we have. We are, we order SARS-CoV-2 PCR testing from the nose or the oropharynx. And those are the symptoms that we consider our initial encounter. Fever, URI, altered taste, other factors. They're sick or they have contacts. And we consider testing also those patients are immunocompromised. They have the chronic problems, children less than 6 months of age. And we have also a pathway to taste as well. The other thing we're able to do is to test every single patient that is going to get admitted. We lost the slides again. We test every single patient that gets admitted, even if they're going to, even for example, if they have appendicitis, are they going to the operating room? Because we have found that up to 1/3 of our patients are positive and they have no other symptoms. So we decided to test everyone. If we can put the slides back, that would be great. Ricardo.
This slide?
We lost the slides again.
Okay.
Okay. I can show you the next slides. The next slides are important because the next slides are our current patients. So if we can't put the slides back, we can see that.
Non si capisce. Questa. Non senti.
No.
Questa?
Ok. No, aspetta.
This slide, Camillo?
We're not seeing the slides.
I don't understand, Camillo. It's very difficult to hear.
Che non vede le diapositive, ma non le può spiegare senza farcele vedere? Why don't you speak without showing your picture on your computer? You can see the picture on your computer, but you can speak also. We don't see the slides.
All right, I have another idea. Okay, I have one more idea. Here. Can you guys see that?
Okay. Perfect.
That's better?
Okay.
Okay. So, okay, so I was saying we test is it look okay? Yeah. So we test everyone that gets admitted, even for example, anesthesia, they're going for surgery because anesthesiologists want to know if they're in risk. And we found several patients that are positive with no other symptoms. We also were able to set up a testing site outside the hospital in a park, as you see. And we have a method in which local pediatricians can refer their patients to get tested there. And this has been very helpful because we've tested in weekdays around 80 patients and weekends around 120 patients per day. And that is an incredible help. So these are not coming to our emergency department to be tested, right? So it's been very, very useful for us.
Sure.
This is our current, this is data as of the 27th. So this data is as of a couple of days ago. And we have tested in our hospital without the outside. We've had 164 positive patients. 43 of them have been admitted to the hospital. They created one entire floor in the hospital, which is the 5th floor. They created a special isolation unit. So they're not all negative pressure rooms, but they are cohorting, like they're doing in other places, the positive patients. So we have 33 patients, and this is as of 2 days ago. 33 in the unit and 10 pediatric intensive care unit patients. We have currently, and we can send it here. We have currently, right now, 12 are admitted in the hospital today. There are 8 in our special unit, and there in the ICU, there are 4 positive ones. Also, as part of our commitment with the region, we are the only pediatric hospital that, well, there's 2 other pediatric hospitals. Well, the one pediatric hospital in the near, we cover 3 different states. So we are helping see adults. So we decided to see adults up to 30 years of age, both in the emergency department for certain conditions and also admit adults with certain conditions. So right now we have 2 young adults, 23 and 25 years old, that are intubated in the intensive care unit. And we are planning to continue admitting adults that have oncology problems and adults that have sickle cell disease, which is very common in our population, and some adults with congenital heart disease, which are already seen in, by the cardiologist. And then the daily census has been around 8 to 10 patients per day that are positive. Okay. Down here, you guys can see the breakup in years that we had. So we have a good number under 1 year of age. The youngest patient we've had was a 3-week-old patient, and we've seen less in the middle years, and then another big spike, obviously, in those that are a little bit older. So as you see, the green ones are the ICU, critical care. So more adults or older kids have been admitted from critical care, and also the less than the 1 year of age. Let me go down next slide. Okay, and also to address the specific other things that we've seen. So like I said, 3 weeks to 25 years that are admitted. Curiously enough, most of our, well, it's very similar, but most of our patients are female. And when you look at the data in Wuhan and some of the data in the US, they tend to be more male, but we've seen a couple more female, and they're getting more. And the other interesting thing that answers one of the questions is commonly, obviously, the patients have runny nose, sore throat, fever, maybe some cough and congestion, maybe some diarrhea and vomiting in a small amount of them. We've seen, like I mentioned before, about 1/3 of the patients that we've tested have had no specific symptoms. We've had I remember I had a couple of weeks ago, a 12-year-old with an acute appendicitis. She has no symptoms, just a regular quadrant pain. And well, she had a fever and she was positive as well. But not necessarily what we think about. Underlying conditions, half of our patients have underlying conditions that have been admitted, and 7% of those that are admitted to the critical care areas have underlying conditions. And these are the ones that we're seeing more commonly. Asthma, 23% overall, and then those patients with chronic neurologic problems like static encephalopathy, microcephaly, global depression, more of those get admitted, around 18%. And the rest of the 3%, which are usually not admitted, are obesity, endocrine patients, cardiac patients, some oncology patients, and some one lupus patients. Okay, so that's the information that I had prepared for you today. I think I have several minutes left. If anyone has any specific questions for me or for what we do here in Washington, D.C.
Okay, 5 minutes.
And apologies for all the problems with the slide.
It's okay. It's okay. Thank you very much.
Scusate una domanda. Sì, un attimo, prima che continuate. Quando io proietto le diapositive, nessuno deve spingere il pulsante present now o immettersi, perché sennò fate saltare la presentazione delle diapositive del collega e poi alteriamo le presentazioni, per cui state attenti, non toccate assolutamente i comandi. Grazie. Vai Raffaele.
Luca just asked a question about cutaneous manifestations of the disease. We have not, that I know of. We have discussed it very much. I'm actually at 4 p.m. I need to hang up because I'm having another meeting with the Latin American Society and the Spanish Society. And we've discussed, and now there's some papers that have come out with some concerns with similarity with Taki disease. But that I know of, we've talked about it. Actually, we have one of the dermatologists talk about this discussion that's been going around about manifestations. And I think what we know, and it's probably what you see in autopsies in Italy, which is the place I've done the most autopsies in the world, is the microvasculature inflammatory changes. So when biopsy these lesions in the skin, they see complement aggregation in the microvasculature. So they think that that is part of the problem that we see in the lungs and in the brain and in the kidneys too, is part of that microvasculature involvement with the virus and complement deposition. But again, that I know of here where we haven't seen or we haven't biopsied it, but we are looking for it.
Ok. Ok, allora a questo punto, thank you very much, Camilo. Do you have thank you for presentation.
Prego, grazie.
Okay, go ahead with the program. Benito from Spain, Basque Country, University of Spain, Benito Fernandez. I don't see really right now. Benito, are you ready?
Benito is the president of the Pediatric Emergency Society of Spain.
Right now, be honest, I'm not able to see Benito. Did you, Riccardo? Lo vedi?
Adesso vedo. A che ora era Benito? Alle 15.
Io direi di andare avanti perché io non lo vedo. Non so se è la stessa mia.
Strano che Benito.
I'm texting him.
Un attimo che lo cerco, un minuto, datemi un attimo.
Sì.
May I ask a question to Camilo?
In the meantime,
Yes,
Did you see any difference on race in your patients?
It's a good question. We haven't discussed it. I don't know. The answer is I don't know. The other part of the answer is that we see a lot of African American people because we are in and the population we see. But I cannot tell you if more.
È arrivato Benito.
What I can tell you is that what we know is that African Americans, adults in general, get, because of the risk of comorbidities, hypertension, other things they have, sickle cell, they tend to be, and obviously access to care is different, right? So we've found that for social and demographic reasons, they have been more impacted in general, right? I don't know in my hospital if we've seen more if we have raised disparities.
Thank you.